If you are over 70, or if someone you love is heading into surgery in the coming months, I need you to stay with me for the next few minutes, because there is a question almost nobody thinks to ask before they go into that operating room. A question your surgical team will likely never bring up on their own, and by the time this video is over, you will know exactly what that question is, how to ask it confidently, and what for specific alternatives exist that could protect the most important organ in your body. Not your heart, not your joints, your brain. I am Dr. Joseph, and I have spent decades working as an anesthesiologist. I have stood at the head of that operating table more times than I can count. And what I am about to share with you is something I wish every patient over 70 heard before they ever signed a consent form. When most people find out they need surgery, they focus on the surgeon. They research the technique, the success rate, the recovery timeline. They worry about the incision, about the pain, about how long before they can walk normally again. And all of that makes complete sense. Those are legitimate concerns, and I am not dismissing a single one of them. But here is what I have watched happen year after year across 3 decades of clinical practice. For patients over 70, the surgery itself is often not the greatest risk. The greatest risk is the type of anesthesia, specifically general anesthesia, the kind that puts you fully under, where your brain is chemically suppressed to a deep level. A breathing tube is placed down your throat, and the machine takes over your breathing entirely. For a healthy 40-year-old, the brain recovers from that. The body bounces back. A week later, they feel like themselves. But for someone over 70, that pharmacological shutdown of the brain can trigger something that does not simply disappear when the surgery is over. It can stay with you long after the stitches are gone. Here is the biology, and I want you to understand this clearly because once you do, you cannot unsee it. The aging brain has something called cognitive reserve. Think of it as the brain's buffer, its ability to absorb a chemical shock. Younger brains have plenty of that reserve. Older brains have significantly less. The margin for disruption is genuinely narrower. On top of DAT, the liver and kidneys in a patient over 70 clear anesthetic drugs far more slowly than in a younger patient. The drugs linger. The brain's exposure to those chemicals is prolonged in ways the dosing schedule does not always account for. What happens as a result? In roughly 30 to 40% of patients over 70, something emerges in the first 1 to 3 days after surgery, called post-operative delirium. And I want you to understand what that actually looks like in a real person, not in a textbook. The patient wakes up and does not know where they are. They believe they are somewhere from decades ago. They become agitated, or they go completely still and unreachable. Sometimes they do not recognize the family member standing right beside them. A daughter once described it to me this way after her father's knee surgery. She said he looked at me like I was a stranger. His eyes were somewhere else entirely, like the person I knew was behind a frosted window. That family had been waiting in the corridor expecting their dad to be a little groggy. What they found instead was genuinely frightening. And here is what makes this even more serious. Delirium is not always temporary. In a significant number of elderly patients, it is followed by something called post-operative cognitive dysfunction. The memory does not fully return. Processing speed stays sluggish. That sharpness, that quickness, the ability to track a conversation, recall names without struggling, follow through on a thought, it is diminished. Sometimes for weeks, sometimes for months. In some patients, the evidence suggests the decline does not fully reverse. A person who is driving independently, managing their own finances, cooking for themselves, living fully, quietly becomes someone a family member is now helping. And the surgery that was meant to improve their life becomes the marker in time when everything changed. Now, the critical question is this: does it have to be this way? For many procedures, absolutely not. Because there are 4 specific regional anesthesia techniques that allow a patient to undergo major surgery without deep brain suppression, and I am going to walk you through all 4 right now. The first is peripheral nerve block, using real-time ultrasound imaging. A small amount of local anesthetic is placed precisely alongside the nerve bundle serving the surgical area, whether that is the shoulder, the knee, the hip, or the hand. The result is complete numbness of the operative site only. The patient is awake or resting in very light, comfortable sedation. The brain is not suppressed. There is no tube, no ventilator, and the block continues working for 12 to 24 hours after surgery, covering that first critical day of recovery and dramatically reducing the need for opioid painkillers, which carry their own cognitive risks, for hip replacements, knee replacements, and shoulder repairs. This technique is genuinely transforming outcomes in elderly patients. The second is epidural anesthesia, which is the right approach for larger operations involving the abdomen or chest. A thin, flexible catheter is placed in the epidural space just outside the spinal cord membrane. Local anesthetic is delivered continuously throughout the operation, covering the surgical area with consistency and precision. The brain is largely spared the deeper chemical burden. The catheter stays in place for 2 to 3 days after surgery, managing pain with a fraction of the systemic drugs that would otherwise be required. Earlier movement, fewer respiratory complications, and a fundamentally better recovery trajectory. The third is spinal anesthesia, distinct from epidural, and preferred for procedures below the waist. Hip fractures, knee surgeries, bladder and prostate operations, lower abdominal repairs. A single precisely placed injection delivers local anesthetic into the cerebrospinal fluid in the lower lumbar spine, creating complete numbness from roughly the waist down. The patient can rest quietly, doze lightly, or even listen to music. The brain is not chemically suppressed to the level of general anesthesia, and the patient maintains their own airway throughout. The data on delirium reduction with this technique compared to general anesthesia is consistent across different countries, different patient populations, and different healthcare systems. The fourth technique, and this one surprises people, is conscious sedation combined with local anesthesia. This is for smaller procedures, such as cataract surgery, carpal tunnel release, minor hernia repairs, or skin biopsies. The patient is relaxed and calm. Anxiety is absent, but they are not unconscious. If someone says their name, they respond. The local anesthetic handles pain at the surgical site directly. The brain carries none of the full pharmacological burden of general anesthesia. For cataract surgery alone, a procedure that takes under 20 minutes, and experienced hands, many elderly patients are still receiving general anesthesia, purely out of institutional habit. Conscious sedation is perfectly adequate and measurably gentler on the aging brain. So here is what I want you to do. Before any surgery, write these 4 options down and bring that paper to your preoperative consultation. Then say this to your team. I've read about the cognitive risks of general anesthesia for patients over 70. Can we discuss whether a regional approach is appropriate for my specific procedure to reduce the risk of post-operative delirium and cognitive dysfunction? That question signals that you are informed and specific. It opens a real clinical conversation instead of a reflexive reassurance. If the answer is that general anesthesia is genuinely necessary, ask why. What specific aspect of this surgery makes a regional technique insufficient? That is a fair question, and it deserves a fair, specific answer. The surgery protects the body. The right anesthesia protects the mind. And at 70, at 75, at 80, your mind is worth fighting for. If this video helped you or someone you care about, please share it. It takes 30 seconds and it might genuinely change the conversation they have with their doctor before it is too late. And if you have not subscribed yet, please do so right now and hit the bell so you never miss a video. I cover these kinds of critical, underreported medical issues regularly because informed patients receive better care. Full stop. Drop a comment below and let me know if you or a loved one has experienced anything like this after surgery. I read every comment, and your story might help someone else ask exactly the right question at exactly the right time.